Hello, the time is now 12:30 Eastern. This is the official start time for today's broadcast, Integration, Behaviorally Enhanced Primary Care. Your host today is Matthew Prentice, and our featured guest speaker is Ebony Winford. And now, without further ado, I'd like to hand things over to Matthew Prentice, the task lead for behavioral health for Alliant Quality. Sir, the floor is yours.
Hello, and welcome to Alliant Quality's Learning and Action Network for Improving Identification of Depression and Alcohol Use Disorder in Primary Care. As Alliant Quality's Behavioral Health Task Lead, I would like to extend my appreciation to you for participating in today's learning event and for your commitment to improving the behavioral health outcomes of the patients you serve. Before we begin with today's presentation, I would like to remind you that in addition to our free monthly Quick-N-Rs, we also provide free evidence-based tools, resources, and technical assistance to enhance your service delivery, operational efficiency, and overall leadership capacity. I encourage you to take advantage of these opportunities and to frequently engage with us to share your ideas and best practices as you initiate and refine your implementation processes. And now, it's my honor to introduce our featured guest speaker, Dr. Ebony Winford. Dr. Winford is a behavioral health consultant and licensed psychologist at Cherokee Health Systems in Knoxville, Tennessee. She is involved in workforce development and is a member of the training committee of Cherokee Health Systems APA-accredited clinical psychology internship and the APPIC-approved postdoctoral fellowship program. She is currently involved in multiple integrated care initiatives, including the Refugee Medical Screening Process and the National Institute of Medicine's Precision Medicine Initiative. Additionally, she consults with primary care organizations as they seek to integrate their practices. Welcome, Dr. Winford.
Good afternoon, everyone. I'm very thankful to be a part of today's presentation. Recognizing that we only have about 20 minutes to get through some good content, I'd like to go ahead and jump right into today's presentation. As Jen indicated, if you have any questions, please feel free to type them in the queue, and we will recognize them, direct them to all panelists. That way we'll be able to see them as they come up. So today I want to spend about 20 minutes speaking with you about behaviorally enhanced primary care, which is really what we're thinking about when we're thinking about integration. At the conclusion of today's presentation, I'd really like for everyone to be able to have a basic understanding of how they're going to determine the level of behavioral health integration present in a primary care practice, but also have some resources to know where you can go to rapidly access information related to the latest information and evidence regarding integrated primary care. Whenever we give a presentation about integrated care, we always like to start with a screenshot and a snapshot of kind of the buzzwords and the buzz titles that kind of permeate the media that we see today. So the latest one for this is maybe 2010, 2015, I think, maybe up there. But these are just some titles of articles, of news publications, of quick, blurbs of information that are disseminated across multiple listservs and websites. But the interesting thing about this is that it makes it sound like integrated care is the biggest, baddest thing around. The interesting thing, though, is that it's very rare that anyone talks about the systematic definition of what integrated care is. So I'm going to take us a couple steps backwards. Before we talk about how integrated are you, let's talk about what integration is and why we even have integrated primary care. All right, so again, let's talk about that rationale. I'm sure some of you have probably seen this slide as well as the ones that will follow. But the National Comorbidity Survey replication, which was done in 2010, showed us that using DSM-IV disorders, there are approximately 46% of the population who would have any type of DSM-IV diagnosis in the entire population in their lifetime. That's almost half of the population in the United States that would have some type of behavioral health condition. When we break it down by type, which is most relevant for us right now, 21% of the population has some sort of mood disorder, and that can include symptoms such as depression and or bipolar disorder. And about 15% of the population in their lifetime would be diagnosed or meet criteria for substance abuse disorder, which may include alcohol, substances like marijuana, cocaine, things like that. If we look at it from the 12-month prevalence of these same types of disorders, 26% of the population will have any diagnosis or meet criteria for any DSM diagnosis this year alone or within the past 12 months. Again, breaking it down by type, 10% meet criteria for mood disorders, and about 4% of the population meet criteria for substance use disorder. So what does this mean for us? Well, these people got to get help somewhere. Unfortunately, more than half, about 59% of individuals who meet criteria for those diagnoses do not get any treatment. It could be because they don't have access to services. It could be that there's lack of insight about the need to services. It could be that when they present for care, these diagnoses are being missed because we're not screening for them and capturing them in real time. We do see that 41% of individuals are in fact receiving treatment for the mood disorders, the substance use disorders, or the other DSM diagnoses that we identified at the previous slide. What's even more interesting about this breakdown of those who do and do not receive care, of the 41% who receive care, the interesting thing is that more than half are coming right into that primary care practice. So it's not just the mental health provider, such as a psychologist, not just a psychiatrist, not just human services or inpatient hospitalizations. They're walking into their primary care provider and saying, hey, doc, I don't feel well, or hey, doc, my head hurts, or hey, doc, my belly hurts. If we are not routinely screening for depression for substance use, we're missing 50% of the population that is going to actually get care. We're missing a big opportunity to intervene for them at the point of care. When we break this down even further, we see there's kind of a breakdown with adults with mental disorders and or medical conditions. So there's a large level of comorbidity between behavioral health conditions and medical conditions. So if we look at this chart here, we see that 25% of the adult population has a mental disorder. And this is roughly a few numbers off from the National Comorbidity Replication Study, but very, very close. We see that 58% of the adult population has some type of medical condition. Here's where the numbers get really exciting for me. 68% of adults with mental disorders also have medical conditions. 29% of adults with medical conditions also have mental disorders. In the primary care world, we're going to have the biggest bang for our buck with this 29% of the adults who have medical conditions who also have mental health disorders. We will miss that bang and lose the buck if we don't screen for them and capture them when they come in to see us. So again, let's take the step back. We're talking about why do we even want to do integrated care, but we haven't stopped to talk about what integrated care is. AHRQ convened a panel of experts, and they literally sat in a room for a weekend, and they argued with each other, and they hashed it out. They read research, they debated. Long story short, they came up with a definition of integrated care, which is really considered the gold standard and the measure against which we determine whether or not a practice has achieved this goal. So I'm just going to read it verbatim because I think it warrants that careful attention. So integrated care is the care that results from a practice team of primary care and behavioral health clinicians working together with patients and families, using a systematic and cost-effective approach to provide patient-centered care for a defined population. This care may address mental health and substance abuse conditions, health behaviors, which may include their contribution to chronic health, medical conditions, life stressors and crises, stress-related symptoms, and ineffective patterns of healthcare utilization. And I think what's really relevant for our discussion today and the overall goal of the Alliance work group is this idea of addressing mental health and substance abuse conditions in a team of primary care and behavioral health clinicians working together. And so we really want to use this as our guiding framework for what we're even talking about today when we're talking about integrated care. So what are the goals of integrated care? Ultimately, we want to improve the recognition of behavioral health needs because, again, 59% of people are not going to get treatment for their DSM diagnosis. Only 41% are, but of that 41%, 56% are going to come to the primary care practice for that care. So as primary care providers and those who work within primary care fields, we have to know how to recognize the needs of that 41% of the population that will seek out care, and of the 50% of that proportion that will come to you for the help. Another integrated care goal is improved communication and co-management. You know, one of the things I love about working in an integrated primary care setting is that the diagnoses of a patient are not just my responsibility alone. I have the entire team to help me not only identify the symptoms, but develop a treatment plan and an intervention that I can deliver in real time. I communicate with the primary care providers. I communicate with the nursing staff. I communicate even with front office staff. We are all part of the team. The team starts from the second the patient walks in and says, "Hello, I'm here to check in for this visit." We collectively manage those symptoms, so the burden is not on one person alone. Another goal of integrated care is increased availability of behavioral health expertise. You know, depending on what research study you'll look at, you may find that when you offer a specialty referral to a patient from primary care, between 30 and 50% of those patients will not follow through with that referral. If you bring the referral to the patient, guess what percentage of people are going to keep the referral? 100% are going to keep it. So we want to increase the availability where they show up, reduce the barriers that accompany having to receive a referral and get to the next referral for that specialty provider. Again, we're meeting the patients where they show up. This really helps to reduce the stigma if we are embedding behavioral health within primary care. There's nothing weird about going to the doctor. When the behavioral health provider happens to be the doctor that you're seeing that day, again, we're reducing the stigma right off the bat. Another goal of integrated care is that we really want to prevent and really detect at an early stage so we can offer the fastest intervention possible for any of these behavioral health and medical goals and concerns that we're addressing. One of my favorite parts about working in integrated care, I have a lot of favorite parts, by the way, is working in well child checks and well woman exams. Not only do you get to talk about what's normal development, but you also get to figure out when something may become problematic, catch it very, very early, create an intervention, and then start to implement it right away as soon as it arises. And again, when the need for specialty behavioral health arises, a goal of integration is to triage and coordinate access to the specialty behavioral health service. So again, if you are establishing the behavioral health intervention right there at the point of care, the patient's likely going to be more likely to continue care with a behavioral health provider when clinically indicated. So why do we even want to integrate? You know, we realize that there are behavioral and psychosocial factors that bring about the cause and the treatment of physical disease, and sometimes it can get really, really confusing, whereas psychological symptoms will mimic medical symptoms. Medical symptoms will mimic psychological symptoms, thinking about things like hypo and hyperthyroidism. So if we have expertise at the point of care that can help tease those things apart, we're giving really good, well-rounded care and making sure that we're not missing the needs of that 56% of the people who are coming to us in primary care to get their behavioral health needs met. You know, we think about primary care at Cherokee Health Systems as a function. It's not a place, it's not a building, it's not a person, it's a function. And it serves as the first stop for access to mental health disorders for a lot of people. It serves as the first stop of access to medical conditions. It serves as the first stop of access to specialty providers. So we want to function as the gate for individuals who need that care. We have to be able to recognize it so that way we can outline a really good treatment plan to address it. Integration has financial advantages. We see reduced healthcare outcomes. We see reduced costs of healthcare outcomes. We see improved overall healthcare outcomes. You know, if we can reduce symptoms of depression for someone who has a cardiac condition, we'll likely reduce the likelihood that they'll have a hospital readmission following a heart attack. And that's a big bang for your buck right there if you're thinking about the cost of a hospital stay for cardiac care. Patients and providers alike report that they're more satisfied with integrated care. We give better care because the team works together and we're sharing the responsibility. We're capturing multiple domains and multiple determinants of health. And people like it when they can see their specialist or their behavioral health provider all during one visit instead of having to come in, get a referral, wait 4 weeks, then see a new person, wait a couple weeks for your follow-up. If you can do it right then and there, awesome. Primary care providers report satisfaction that they now have more time to focus on more specific medical concerns if they can depend on a behavioral health expert to take care of the other conditions that might affect their ability to take care of that medical care. So in general, people report satisfaction all around. Keep in mind that integration is a means to an end. We want to improve the health of the population, reduce healthcare disparities, improve access. If I can't say another word today, I'm going to say access, access, access. We want to keep the doors open to allow individuals who have those concerns to come to us. We want to screen and identify for it, so that way when it's identified, we can allow them to access the care that they need to address those concerns. Integration is a means to wellness and prevention. Again, we want to do that early detection, early intervention, prevention efforts as much as possible. It's a means to enhance patient-centered care. It allows the patient to drive the treatment plan with consultation with you, the team member, consultation with other team members. All of the team consults with the patient and allows the patient to guide that care. It's a means to making sure that we're really integrating evidence-based clinical and program decision-making. We can't give good population care unless we have the good evidence base to support the interventions that we give. So let's go ahead and get a little bit into the second portion of our purpose and our objectives today is, you know what, where am I on this whole integration thing? Like, where do I fit? Here is a good chart. I apologize for how blurry it is, but if you go to SAMHSA.org and click on their integrated care website, there should be a link in the resources section. It gives you a better version of this. But essentially, this gives us a continuum of integration, 6 different levels, ranging from minimal collaboration to full collaboration in a transform, merge, integrated practice. Here at Cherokee Health Systems, we fall at level 6 because we integrate space, we integrate our electronic health record, we integrate communication, we integrate as far as access, onboarding, accreditation, all sorts of policies. They all affect us all. So we are a level 6, but that doesn't mean you're wrong if you're at a level 1. It just means that we're working along that continuum. So when you get a chance, I want you to access that and look at that more specifically. For now, let's ask a couple questions of ourselves. Here's how you know where you might fall on the continuum. If your answer to this is yes, you're more likely to be closer to the 5 or 6 range on that continuum I just showed. So, does your organization's mission statement include behavioral health, or does it just say something to the effect of, we want to improve medical conditions of our patients? Does your organization's business plan include ways to make behavioral health delivery financially sustainable? Has behavioral health been integrated into all levels of hiring, training, compliance, credentialing? Does your primary care practice have at least one full-time behavioral health provider on site who is readily available and easily visible? I want to pause for this one because a lot of individuals and a lot of organizations say, yes, we have a behavioral health provider. They're just upstairs and around the corner. That's not integration. That's co-location. A truly integrated practice has that behavioral health provider knocking elbows with the medical team, sitting in the same space, looking at each other, talking, being able to turn simply in your chair and being right there and looking at the medical provider. If the medical provider has to go upstairs, go around the corner, and then find the back hall to find the behavioral health provider, that's not integration, that's co-location. Again, not wrong, just not integration, and at a different level of the continuum. Does your primary care practice have a plan for accessing specialty behavioral health services? You know, I've been saying a lot about this whole screening and intervention, but if your primary care practice doesn't have a plan where if you develop a positive screen for depression and substance use and you don't know what to do with it, then you may not be fully integrated. Additional questions to ask yourself. Does your practice routinely screen for common behavioral health concerns that are relevant for your population, such as depression and substance misuse? Does your primary care practice use evidence-based treatments to provide population-based health care? Again, we can't give good population-based health care unless we have the evidence to support us. And does your primary care practice have a fully integrated and shared electronic health record? You're not fully integrated if your primary care providers cannot look at your behavioral health notes. And I know there are a lot of EHR roadblocks for that, lots of funky different laws that may prohibit that. But it's not a fully integrated practice if there are roadblocks and barriers that prevent one team member from seeing the notes of another team member. That's like saying to the cardiologist that they're not allowed to see the endocrinology notes because that's private, that's special. The heart and the kidneys work hand in hand, so if one cannot know what's going on with the other, that's not integrated. Same thing with behavioral health and medical primary care. If there's a roadblock or a barrier between accessing both sets of records, that's not full integration. The last question we'll ask is, does your primary care practice routinely share information regarding patient care with all team members? One thing that a lot of people have is the 42 CFR Part 2, where it talks about sharing substance use information. Informed consent will allow you to share that information across practices. The patients just have to be mindful and have to give your consent for you to share. So here's the thing. If you answered no to those questions, don't worry about it. Again, there's nothing wrong with the level that you're at. These are questions just to ask you so you can ask yourself, where are we? Again, if you answered yes to most of those questions, you're likely around the 5 to 6 mark on that continuum. If you answered no, you're likely closer to the left side. Not wrong, just not fully integrated. So where do you go to find out what's going on with integration? How do you get there? Here's some really good websites and resources that we use here at Cherokee Health Systems. Bright Futures is really important for adolescents and pediatrics. CFHA, or the Collaborative Family Healthcare Association, has recently updated what's called a FAQ section on the website. They also have a PCBH resources or handbook section on their website. If you click on it, there's lots of articles, evidence-based, empirical resources that help you determine at what level you are on that integration continuum, what's evidence-based treatment for the symptoms that you may identify, how do you go about establishing referral resources and community partners once those concerns are identified. Lots of good stuff up there. Again, AHRQ is the one that came up with the official definition of integrated care, so that's an awesome resource there. Depending on the electronic health record that you have, a lot of them have integrated something called UpToDate in it. You click on it within the EHR and it'll give you links to evidence-based practice for whatever the diagnosis may be. SAMHSA, that's the website I was telling you that has that chart of the 6 levels of integration. And then the Academy, Integrating Behavioral Health and Primary Care, ICSI, another really good site. These are a couple resources, including websites. Here are a couple books that we stand by here at Cherokee Health Systems, and in fact, anyone who comes to our training program will read, if not the whole of each of these books, a huge chunk of them, lots and lots of chapters. And here's some other resources, some articles. And as a reminder, we've been talking about screening. This is just a summary slide of the different screening codes that you might build depending on your specialty and your state. That might help once you're actually using those screening tools. And so at this time, I think I'm about 2 minutes ahead of the game, so I want to go ahead and open up the floor for questions. Jen, if you've received any typed into the queue, would you mind sharing those for us?
Of course, Dr. Winford. We have gotten a couple questions through the chat, so I'll verbalize this first one for you. It is, how do you handle logistics of scheduling for patients in an integrated care setting? For example, appointments with the psychologist and physician in one day.
Absolutely. So the psychologist or the behavioral health provider, we like to mimic the schedule of the primary care provider. For example, primary care providers typically see new patients in 30-minute slots and follow-up patients in 15-minute slots. My schedule looks exactly the same. So if I know that a patient needs to see me and the medical provider at the same time, we schedule 30 minutes apart from one another. So the patient may see the primary care at 9. I'm going to schedule at 9:30. That might mean I see them at 9:20 because they're done with the primary care provider, but it doesn't matter as long as they're in there. So what we do is we stack in 30-minute increments. here at Cherokee, our flow is very fluid. So if the primary care provider is running late, even if they're my 9:30 and the primary care provider is 9 o'clock, if the primary care provider is running late and I'm free at 9, I grab the patient at 9, see them, coordinate with the nurse who can then triage them into the medical provider's pod, and the patient is still being seen, the visit's been started, and the primary care provider hasn't been thrown too far off target with their flow.
Thank you. I have another question here. How can a practice ensure that depression and alcohol screeners are consistently used? How are they best incorporated into the workflow?
Again, I can give you an example of what we do here. We have what's called medical vitals as well as behavioral health vitals. And our nursing staff, whether it's a LPN, a RN, or NA, they've all been trained to administer both the PHQ-2 and 9, as well as the NIDA quick screen, red flag items, and the cage aid questions. So what happens if the nurse pulls the patient from the waiting room and starts the triage process? They're going to have the patient stand on the scale, take their blood pressure, take their temperature. Those are the medical vitals. The next set of questions will be, in the last 2 weeks, have you felt down, depressed, or hopeless? In the last 2 weeks, have you had any changes in your energy or your mood? Those are kind of the PHQ-2 questions. And then right after that, how many times in the last year have you had 4 or more alcoholic beverages in one sitting for a woman, or 5 or more for a man? And in the last year, how many times have you used any substances such as marijuana, cocaine, heroin, etc.? Any positive screen or positive response to those, if it's available, automatically generates a behavioral health consult. And I say if it's available because I recognize that not every practice has a BH provider embedded in. But at Cherokee, for us, if those screenings are positive, we come in and see the patient right after. But the nurses make it a routine component of every single visit. That reduces stigma, and it creates the flow. Patients know to get ready to answer those 4 questions right after the blood pressure is taken.
Thank you. So I have a question that's a follow-up to the first question about handling the logistics. It's just a quick one. How does a behavioral health provider bill for 15-minute appointments?
So we're usually going to be about 16 minutes, and that gives us the regular psychotherapy code, 16 to 37 minutes. If we're doing a health and behavior code, we can submit a 1-unit charge as early as 8 minutes. So most of our appointments are going to be between 16 and 30 minutes long, and we'll submit within the 16 to 37-minute code. And that's really important because we want to make sure that we keep our role very specific. In integrated care, we are not doing therapy in 15 minutes. We are doing brief, targeted interventions alongside our primary care providers, and so we don't want to set the framework that we're going to have hour-long consults with our patients. 1, that really blurs the lines for our role, but 2, we're no longer free to help the primary care provider. So we're going to work within that 16 to 37-minute framework and bill for the psychotherapy code with that time frame.
Thank you. So we've got about a minute left to go. I have one more question, and while I'm going to give you that question, I'm going to advance to our adjournment slides, Dr. Winford. So the question is, could you provide some examples of evidence-based treatments to provide population-based health care?
Absolutely. So if we're thinking about evidence-based treatment for depression and substance misuse, motivational interviewing is going to be the way to go for both of those. We want to really work with a patient's level of change and readiness to change, and work and talk in strategic ways to elicit change talk. When we're thinking specifically about depression, we know that solution-focused therapy is really evidence-based and leads to some good treatment outcomes in short amounts of time. We know that behavioral activation is one of the best strategies to use. When we're thinking about medication management, we know that SSRIs for moderate to severe symptoms of depression, and that absolutely has to be coordinated with the primary care provider, especially depending on the state where you work. For substance misuse, we really want to work with the motivational interviewing. Depending on whether or not they're in acute withdrawal or not, we want to give either information about access to detox centers or get them to an ER immediately for medical attention for that. And that's kind of the best evidence base for the substance misuse, is to really go with their motivation, give them access to more intensive services, monitor for concurrent or comorbid psychological conditions that could also make the substance misuse worse.
Dr. Winford, thank you for that excellent presentation, and thank you all for participating as well. Before you go, I'd like to remind you to fill out the post-presentation evaluation. And once that's completed, you'll be able to download your CE certificate. If at any time you have any questions or concerns, please do feel free to reach out to me at the contact information you see before you. I look forward to our continued engagement and your attendance at our next LAN Quickenar on October 20th. More information about this event will be sent out to you shortly. Until then, take good care.
This concludes today's broadcast. Thank you for joining us.